So, what are we talking about today? We know that in myeloma, so much research is happening, and especially in clinical trials right now, there are so many novel new immunotherapies, just so many therapies being developed for myeloma, and especially in the relapsed refractory space. Some of these drugs are called bispecific antibodies, and they are targeting things on the myeloma cell such as BCMA. You might have also heard, CAR T, that treatment targets BCMA. And there's just a lot of treatments now that target BCMA. But in addition to BCMA, researchers have identified multiple other targets on a myeloma cell, including GPRC5D and FCRH5. Those are tongue twisters. And today I invited Dr. Diamond to come talk to us about those different targets and the therapies that are being tested in myeloma treatment to target those specific things on myeloma cells in order to fight myeloma. It's now my pleasure to introduce Dr. Ben Diamond to you. He is a hematologist oncologist who specializes in the treatment of plasma cell disorders, including monoclonal gammopathy of undetermined significance or MGUS, smoldering myeloma, and multiple myeloma. His research interests include utilization of minimal residual disease or MRD guided approaches to clinical decision making, maintenance therapy, and the genomics of multiple myeloma and secondary malignancies that occur for patients treated for multiple myeloma. He completed fellowship at the Memorial Sloan Kettering Cancer Center, spending a year as a chief fellow, and has joined the myeloma group in Sylvester Comprehensive Cancer Center now in Miami, where he is a member of the Myeloma Genomics Laboratory participating in translational research. Dr. Diamond, we're really excited to have you come talk about this exciting new phase of myeloma therapy, and thank you for being willing to speak to us today.
It's my absolute pleasure. Thanks for having me, Audrey. So with that, I guess I will share my screen. Bear with me 1 second. All right, how are we doing? Can we see okay?
Yeah, looks great.
Okay, great. So today, as Audrey alluded to, we are extremely excited about the bispecific antibodies that are being developed in the field for multiple myeloma. I think, as I was talking to Audrey about this before, everyone says they're excited. You'd be hard pressed to find anybody in the field that's not excited about the bispecific antibodies, because they are true game changers that are really revolutionizing the field. They're moving to every single line of therapy, and they can't be stopped for a very good reason. They're quite good. So I'm going to be talking about the other guys. These are the other two targets that are currently in development for the bispecific antibodies that are a bit less far along than the ones that you may have heard of so far for the BCMA-directed therapies, but they're no less exciting, believe me. So here are my disclosures to start. And so today, what we'll be talking about are just a little bit, I promise, of history and mechanism for bispecifics, because I think it helps set the stage for what we're going to be learning about over the next few years, really. The current landscape of the therapies that we have available to us now and the trials that are upcoming, and then some of the other agents, even past the GPRC5D and the FCRH5 agents that are being developed. So first, by the way, sorry, Audrey, to quickly interrupt, you don't see the annotation stuff at the top, right? Nice clear screen?
Nope, yeah, it's clean.
Okay, perfect, thank you, sorry about that. So a little bit of history on the bispecific. So although we're only hearing about them now, they've actually been in development for many, many years. And actually in the 1980s, the first demonstration of this kind of T-cell redirection, which is the goal of bispecific antibodies, was demonstrated. Their popularity really caught on in the late 2010s with the advent of blinatumomab, which is a therapy for lymphoma. This is a CD19, CD3 bispecific agent. It's actually more of a BiTE. I don't know if we need to go into the distinction of that between the BiTEs and the bispecifics now, but suffice to say, it revolutionized the field. It's a continuous infusion because it's a little bit less stable than the bispecifics that we're used to seeing now. But when we saw how much of a blockbuster this kind of therapy could be in cancer, all of the drug companies started developing bispecific antibodies for the use in multiple myeloma. So how do they work? In very basic terms, basically, your multiple myeloma cell has many cell surface markers. Okay, so here we're looking basically at BCMA because it's a very easy one to understand. BCMA is a marker on the cell surface of plasma cells. It's very specific to plasma cells, and for that reason, it's a good target because we can harness the immune system to basically attack a myeloma cell specifically and leave the other cells in the body alone. So myeloma cells will express BCMA. You can give an antibody that has two domains of specificity, one that targets the BCMA and one that targets CD3 on a T cell. And the idea behind these therapies is to basically pull the immune system, to pull the T cells into direct contact with your target cell, in this case, the myeloma cell, to activate the T cell and to let it do its job to kill cancer. So just briefly, I will touch on Tocolysiumap because I know you guys have already had a BCMA session. But I think it helps just to set the context and what we're expecting and how we can compare the other agents with what's currently approved. So most recently with the MajesTEC-1 trial, which was a really kind of pivotal trial that got published in the New England Journal of Medicine early last year, looking at Tocolysiumap, which is the BCMA bispecific antibody for patients that had multiple myeloma, more than four or more lines of therapy. And it got approved with really kind of unheard of results for patients in this risk category. We were seeing overall response rates for patients in the 60 to 70% range, with patients basically having median PFS of about a year. And remember, these are generally patients that are either candidates for CAR T or nothing, honestly. And so to have a therapy that is this efficacious and well tolerated for the most part, at this stage of disease is really quite impressive. And so the things to point out and the things that I want you to have kind of in the front of your mind for the rest of the presentation are some of the toxicities, because that's a lot of where all of these agents differentiate themselves from each other. So what we see in terms of toxicity with all of these agents is going to be CRS, which is cytokine release syndrome. The idea being that if we activate the entire immune system all at once to attack tumor, you're going to get a huge inflammatory response. And this happens with CAR T cells, and this happens with really anything that we're doing to redirect the T cells against the cancer. And so that phenomenon of fever, chills, sometimes low blood pressure, almost mimicking infection, that's called CRS. And with this therapy, specifically on this trial, we're seeing CRS rates of any grade within the 70% range or so. So pretty high. You can basically expect to have that kind of reaction upon infusing this drug, or actually giving this drug. And then ICANS is basically a neurotoxicity syndrome, which is related but not the same as CRS. And I think just for our purposes, we can call it neurotoxicity. We can think about it as confusion, inflammation-related confusion, and some other more serious neurotoxic events. Here, a little bit less common at 15% or so. So this is kind of our benchmark: 70% CRS, 15% neurotoxicity. And then for infections, we are sort of struggling. This is probably one of the biggest issues with Tocolysiumab and with BCMA-directed therapies, is the infection rates are kind of high. And so in this trial, actually 70% of the patients had an infection of any grade toxicity, whereas the grade 3, 4, the more serious infections were on the order of 44, basically in the mid-40s. So one of the main challenges that we're going to have in implementing this treatment and making sure it's safe and available for everybody in the community is really having a good understanding of how we're going to be able to control those infections. So the other targets. GPRC5D is the first one that we'll talk about. This is another really interesting target, and there's some biological important differences between BCMA and GPRC5D. So what I'm showing you here is a nice little figure. So Eric Smith is one of the, I should say, fathers of this kind of therapy. He was one of the first to be able to identify this as a target for use in multiple myeloma when he was working over at Memorial Sloan Kettering Cancer Center. And what he found is basically looking at the expression levels. In other words, where is GPRC5D in the body? You can see in figure A in the top that for looking across all cancers, multiple myeloma has a very high expression of this cell surface marker, whereas other cancers not so much. And then looking below that in B at the normal tissue, what you'll notice is all the way on the right side, the bone marrow is where you're going to find a lot of expression of GPRC5D. And then also kind of anecdotally, you see here, there's some outliers, a lot of expression in the skin. They make the distinction of sun exposed or not sun exposed. I don't think it necessarily matters for us right now, but suffice to say that we do see that these are the two places that you do have GPRC5D in the body. And that I tell you that, and I show you this because it really helps us understand the toxicities that we're seeing with this agent. So the original work was showing that you would see it in the skin, in the hair follicle, and on the surface of plasma cells. Interestingly, when they were looking in mice, despite this being in the hair follicle, what we saw was when we targeted the agent, you did not induce alopecia or hair loss, right? So when we saw that you didn't cause people to lose all their hair when targeting this agent, it became very exciting as a target for therapy in multiple myeloma, because it looked like there wasn't going to be a whole ton of toxicity, but it was going to be very specific for the myeloma cell. Now, the interesting biological difference between BCMA and GPRC5D is that GPRC5D, as far as we know, we don't know what the function of it is. We just know it's on the surface of these cells, and it does not seem to be essential for the myeloma cell to survive. So you can imagine if you've got a protein on the surface of the cell and you start attacking it and really giving it a lot of a hard time, the cell can sometimes decide it doesn't want to express that protein anymore, and it just hides it or gets rid of it, and the cell seems to be able to survive just fine. The opposite is not true with BCMA, where BCMA is actually essential for the myeloma cell to survive. And so it can be a little bit harder to lose. And the resistance mechanisms between these two agents are going to be a lot different. And that's some of the science that's going to be sort of moving forward, so we can really decide which agents for which person. So I know that this is actually a CAR T cell therapy, but I just wanted to show you one of the first studies looking at targeting GPRC5D. So along the same line, with Eric Smith developing this CAR T cell agent and Sham Malankody implementing the trial, testing it, we saw some really cool results. Basically, for the first CAR T cell with an alternate target, not BCMA in other words, using it against GPRC5D, is a small trial, more of a proof of concept, but we do see that there are responses, and the responses are quite nice. And importantly, so we're seeing some nice MRD negative rates, so very deep responses. And importantly, what we're seeing is that for patients that had previous BCMA therapies, they're still able to respond to this. And that sort of makes sense. If you're going to attack a different target, you should be able to get a response, even if there is resistance to the other target. So here showing proof of concept that this is something that we can do. So then moving forward just a few months, we have the first bispecific antibody published for use with multiple myeloma. This is actually another Janssen product. The first was Tocolysiumap. This one is Tocolysiumap, targeting GPRC5D. Another big paper. You can see everyone's super excited about these things. It's another New England Journal paper. So I can show you just some of the takeaways, okay? So for this GPRC5D directed therapy, we had a phase 1 dose escalation. So it's an early study. Mostly the goal of a study like this is to look for safety signals and to also try and find the recommended phase 2 dose, really to try and find what dose is going to be most safe, but also promising for efficacy when we move it up into the more advanced clinical trials. They tested a bunch of different formulations, a bunch of different step-up dosing strategies. In other words, it's a little dangerous to give a full dose of this drug kind of at the very upfront. And so most of these bispecific drugs work on a step-up strategy where you give a little bit of the drug and then a little bit more of the drug, and then finally a full dose. So there's various strategies implemented in this trial, again, looking for safety, giving it IV, giving it subcutaneously to a pretty large number of patients. And these are patients that are basically refractory to everything else, or at least unable to tolerate everything else. And importantly, you basically have people that have had 6 prior lines of therapy, which is quite a number. So these are patients that are really hurting and needing something. Ultimately, they were able to define a phase 2 recommended dose. There's actually 2 of them, one that's a weekly dose and one that's an every other week dose, which makes things easy, of course. And then finally, we had on this trial, as you can imagine, a number of patients that had already been exposed to agents targeting BCMA. And in that case, so this is actually wrong. It shouldn't be 8%. It should be 50%. It's half of them responded. So again, really nice. People that had already progression on the BCMA directed therapies are able to respond to the GPRC5D drugs. So I know this is very small, but bear with me because I will point out a couple things here that I think are worth knowing. These are basically, the tables that you're going to see in any study that you're looking at. You're going to see the characteristics of the patients that were enrolled. And then I didn't put the responses here because we'll talk about that later, but I'm also showing the adverse events in the other table, okay? So the things that I want to point out and some things that you can use to critique some of the therapies that are being proposed or being presented is kind of looking to try and understand what kind of patients were being tested here. So one thing that I like to point out here is the median time since diagnosis, okay? And so what do we understand here? So patients in both of these treatment arms, again, it's just a slightly different dosing strategy here, but they're both good doses. We see that the median time since their initial myeloma diagnosis is about 6 years. Okay, so what do we know? We know that with people that have standard risk multiple myeloma who get basically standard induction with a triplet like VRD, for example, and then a transplant with maintenance to follow, the median survival, as we've seen in some of those transplant studies, can be 10 years or more. So when you see that patients have gone through a large number, basically six median lines of therapy in 6 years, you know that the people on this trial are probably going to be high risk, regardless of what their cytogenetics show. Just the way their disease is behaving, the way that they have progressed through all of these therapies so quickly tells us that functionally their myeloma is aggressive and it's behaving in such a way that it's ripping through a lot of the prior therapies. Okay, so that's one thing to note. Then we also see that there's extramedullary disease. As we have heard before, this is disease that grows outside of the bone marrow. It's a marker of high risk. And on top of that, they also do show that there are a number of patients with high-risk disease. These are the high-risk cytogenetic abnormalities. Not super high, but again, I think superseded more importantly by this kind of functional high risk that we talked about before. And then finally, the last thing that I want to highlight in this table are the number of prior therapies that were given before. And I think what's important and most relevant to us in the community are people that are getting basically all of the known myeloma drugs. We call that pentadrug, right? So I'm going to list them, but you know them well. They're the bortezomib, lenalidomide, daratumumab, pomalidomide, and the carfilzomib, right? So if you get all 5 of those and you're refractory to those, then you're considered pentarefractory. And that's important because, again, it really highlights how aggressive the disease is and how much has happened before we've gotten to this point. And so here, remember that number is 20% because you're going to see some trials that kind of blow that out of the water, but still nothing to sneeze at here. So those are the kind of patients in general, relatively high risk population. And then for the adverse events, the most important thing is sort of what we talked about before. Everything gets divided up here, and I think it gets a little bit lost. But the things that I want to point out are the things that make this different than the BCMA directed therapies. Okay, so we talked about GPRC5D before being expressed in the skin and in the hair follicles. And so you will see that there are things that you wouldn't expect with the other agents, right? So there are nail related events, there are skin related events, basically rashes, or fingernail lysis or irritation. And then interestingly was dysgeusia, which you'll hear a lot about these days, but that's basically a change in taste. It's dysfunctional taste. And it's been shown also that GPRC5D, now that we've been seeing the side effect, is actually present in some of the structures in the tongue so that you get the inflammation there and a loss of your taste buds. And so that's sort of a unique toxicity. And it's not nothing, okay? So of any grade, we are seeing, in the 60% range for that loss of taste, for the skin-related effects. And so that's something we really have to be aware of. Now, what's important, though, is that the infection rates are far, far lower, okay? So here with the talquetamab, there were 47% or so, 47 and 34, depending on which of the dose levels we're looking at, had an any grade infection. You compare that, again, I know it's across trials, but you compare that to the BCMA, it was 70% there. So here it's a lot lower in the 40% range. And the grade 3-4 infections were only 7%. So the serious infections were under 10%. So there's a completely different side effect profile we see here. While the kind of core side effects, that cytokine release around 70%, is very similar because they have similar kind of mechanisms. It's the same idea. We're getting the T cells to attack the tumor cells. We see that same inflammatory response. The choice in the target will sort of govern some of the other side effects that we're seeing. And so you can imagine in the future when we have a choice, which of these two, it'll be great when we have a choice, but when we have that choice of what we can use, we're really going to be looking at that side effect profile and helping, decide patient and doctor together what sort of makes the most sense for that person. Maybe if they're a little bit more frail or a little bit more susceptible to infection, we kind of want to stay away from the BCMA, and maybe we lean a little bit more into the GPRC5D. Okay, and I did have the tocilizumab side effects up here, but for the most part, we did discuss all of those in comparison. So in terms of responses, I told you I would show you the responses. I guess I'm showing the responses after we talked about the side effects and the adverse effects, but it's mostly to show that they're quite similar. Okay, so we're seeing, again, very similar to tocilizumab, that there are responses in the range of 60 to 70%. So really quite nice for a very similar patient population. Okay, now we can, sorry. There we go. Now, before I move on to the other targets, I just want to go on to show you that people are already talking about what can we do next? How do we decide how we can optimize these treatment strategies? And so, of course, if you've got one of these agents, you might as well combine both of them together. And so this is a study that's ongoing. There's a little bit less data for it because it's a newer study, as you can imagine. In fact, this is data that was presented actually just earlier this month, a couple of weeks ago, for the Redirect study, which is combining a BCMA-directed therapy and a GPRC5D directed therapy together to see if it is safe and tolerable for patients, and to try and define what doses are going to be safe for people. So I think this is an important concept, right? So theoretically, you may not expect the response rates to be that much higher combining these two agents, again, because it's the same mechanism, right? You're basically combining two drugs that act in the same way, that activate the immune system against the T cell. You're expecting that maybe you'll have a little bit of a better response, but more importantly, I think what we're going to like to see, and what we can't really answer right now, is how this is going to do over the long term. You would imagine, though, that it's going to be better over the long term because the myeloma cell is going to be less able to develop resistance to two drugs in combination versus one. So again, as we'll see, basically, I'll talk about that in a second. Sorry about that. So basically what we're going to see is that the response rates are going to be probably one of the more important things that we aren't really able to discuss as much right now. But some of the things that are worth noting, again, are the kind of characteristics of people in this study. Some less number of therapies, but we are seeing that there are a number of penta-refractory patients, very similar to what we saw with the other two trials. And again, you would also expect infection rates to be a little bit higher if we combine these two drugs. And as you can imagine, they are, right? So with tocilizumab alone at 44%, grade 3 and 4 infections, here it's about 50%. So hard to say if there's a true difference, but at least it doesn't seem like the combination makes things that much worse in the realm of infections. And so here, again, the overall response rate is higher, which is not totally expected, but it's quite nice to see. So here we're getting a pretty good response rate out of the combination of these two drugs, again, in the same kind of disease setting versus either of the two agents alone. And again, what I mentioned is that I think for me, the more important thing is going to be seeing how long this response lasts. I really hope that it's going to be more durable than either of those two other agents, it by themselves. To combine them, I would hope that there's something longer. Okay, so then other combinations before we move on to the last target. There's the TRIM2 trial. So of course, another combination looking at talquetamab and dara. I won't talk too much about the data because again, it was just very recently presented. But the nice thing about it is that they're allowing patients that are refractory to daratumumab to try and get on this trial as well. Okay, and then there's another GPRC5D directed agent, very similar to talquetamab, called furintamig, also a little bit earlier on in development. But what I wanted to show you here is that we're seeing pretty similar response rates here when we use the same kind of therapy, the same kind of idea. Although here, what's interesting is for patients that are penta-refractory in this trial, again, hard to compare across trials, but just one thing I wanted to point out is that here, it's basically double the number of patients on these treatments, on this treatment that is penta-refractory or refractory to all of the other treatments available. And we're still seeing these really good response rates. So it's going to be interesting to see over time if there's really truly going to be a difference in these agents, or if this is kind of all just statistical noise. Suffice it to say, we're still seeing really nice responses in the most resistant disease. Okay, so to move on to the next agent and the next target. So FCRH5 is another cell surface marker. This one is specific to B cell lineage. It's expressed in B cell malignancies. Not limited to multiple myeloma, but of course on multiple myeloma. And you've probably heard all the buzz about the location of chromosome 1q before, and that is exactly where FCRH5 is located. So some of the early research was looking at chromosome 1q and actually looking at the expression levels of FCRH5. And I put this here just to show you that here with a gain of 1Q, you actually do have a higher expression level or a larger amount of this FCRH5 target. Now, biologically, that may not be so important, but the reason I bring it up is because you've probably heard of hyperdiploid disease, where there are gains on odd numbered chromosomes, excluding chromosome 1Q. And there, what we have seen over the past years is that the expression level of genes is not necessarily higher, even though there are duplications in those hyperdiploid regions. Although here, with the gain 1Q, we really see how strong a driver this gain of 1Q is across the board, where all the genes that are expressed on 1Q, whether or not they're truly making the disease more aggressive, they're all expressed at higher levels, right? So that alone, just looking at this, kind of gives us a little bit of an insight into the biology of the disease. Nevertheless, I don't think any of us really expect this difference in expression to impact responses. So in other words, I kind of head that question off right here off the bat. I'm not convinced that people that have a gain of 1Q are going to be any better kind of a candidate for this drug. I think it's just going to be a good target in general for patients that have multiple myeloma. So the drug that is furthest along in development is Avastamab. This is a really cool drug. I'm actually very excited about it because of how durable some of the responses have been. So I kept talking about that pentadrug refractory status. This is a phase 1 trial. So again, not designed to look at efficacy, more designed to look at safety. But we see that like a tremendous number of patients are pentadrug refractory. So here, 70%. So this is, basically triple what we're seeing in the Tocolysiumap and Tocolysiumap studies. So again, we can't compare the agents head to head. It's not what this is designed for, but it's just very reassuring to see how many resistant patients are able to enroll in these trials and get really nice responses. What I'm highlighting here in this data that was presented by Joshua Richter just very recently were the patients that had actually been treated with Avastamab and then had to come off treatment early for any reason of adverse events. So maybe it was an infection or some other side effect that was troublesome that caused them to stop the therapy. The great thing was that you see all these yellow dots. These are the yellow dots that show where people stopped the drug, but you see that even after stopping the drug, these patients that stopped are still having a response, right? It shows that there is a durable immune response against the myeloma. And you really love to see this because this means that maybe in the future, we're going to be able to come up with really nice dosing strategies that don't involve continuous dosing, that don't involve getting this every week or every other week. If we see that people are going to have a response for many months after stopping the therapy, we basically are able to generate long-lasting immunity. And that's really, really, really nice to see. So you can see here that for these specific patients that had to stop therapy within a certain amount of time for an adverse event, the median time on the treatment was 6 months, but the median time that they were on study was basically, another 13 months after that, after they stopped therapy. So, in some cases, a tremendous amount of time. So then other things that are being done with Avastamab are pre-treatment with Tocolysiumap. So we talked about CRS before, the cytokine release syndrome. So if everybody's experiencing this, if it's like a 70% risk of CRS, I mean, here you see 90% risk of CRS, that's going to be one of the main limiting factors for us being able to give this out in the community because it's tough to manage. You really need close care and generally the recommendation is for hospitalization so that you can be monitored when you receive this drug. So one of the ways to mitigate this was to try and give Tocolysiumab with that. And this is an anti-IL-6 antibody. Basically, it's designed to interrupt that inflammatory process. So Suzanne Trudel had presented this data up at ASH in December, looking at Avastamab with pre-treatment and without pre-treatment of Tocolysiumab beforehand. And you can see that there's a huge difference in the amount of CRS. And importantly, although it doesn't quite look like it here, although it looks like the patients that had Toci had a little bit of a better response rate, I think that the numbers here are a little small. And so I wouldn't really come away with saying that, getting Toci augments the response. I would just say that in general, we don't think there's a difference in the response rate between people that are getting Toci and people who aren't getting Toci. And so for that reason, it seems like sort of a really nice thing that we can do to prevent some of the toxicity and to make the hospitalization shorter. And as a very brief aside, I will mention that here at University of Miami, Sylvester Comprehensive Cancer Center, our strategy has been to adopt this exact same approach. And so when we're giving, right now the standard of care drug is Tocolysiumab, when we're giving that in the hospital, we are pre-treating as well with Tocolysiumab based on the results of this abstract. And we are seeing that we're able to speed up that hospitalization time, people don't have to stay for the full 9 days. They're basically out in 7, and the CRS rates are much lower. So it is a good strategy, and maybe in the future it'll be a strategy that lends itself towards transitioning people from having to be admitted towards maybe being outpatient, and making this a little bit more doable and more available to people that aren't close to an academic center. Okay, and then finally, some other targets that you'll hear about in the future. I just selected a couple of them that we have open here at Sylvester. So there's a Sanofi drug that's actually a tri-specific antibody. The idea being to augment the T cell response against CD38, which is the target that Daratumumab goes after. And there's also an Ichnos drug that's a bispecific, sort of novel, right? Because here we're not binding to T cells here. We have a CD38 target on the myeloma cell, and CD47, which is designed to inhibit the don't eat me signal on monocytes, which you may have heard of before. Basically, it's telling the immune system to go ahead and not ignore your myeloma cell. So basically just augmenting that Daratumumab response. Things that we're going to look forward to, and I'm sure things that are basically questions that I think every one of us is curious about. So there are broad innovations happening. So, we've discussed, these 2 extra targets, GPRC5D and FCRH5, but already we're seeing that there are bispecific strategies directed against CD38. And so in the future, we're going to see probably more targets than just these. As time goes on, we're going to have to really understand and get comfortable with the unique toxicity profiles that are seemingly target dependent. And once we really get a handle on those toxicities, I think it's going to be a lot easier to give these drugs. You're going to see already that there are earlier lines of therapy with the bispecifics that are planned. So there are newly diagnosed multiple myeloma trials opening up with these bispecific agents. And even then, there are also trials using these bispecific agents in smoldering multiple myeloma, and high-risk smoldering multiple myeloma, with, again, the rationale being that if the immune system is a little bit healthier in those early phases of disease, maybe we even get more bang for our buck, right? If the immune system is healthier and we get it to attack the myeloma in an early phase, we might see better results. There's combinations, which we already touched on. So trying to figure out if these drugs play well with others and whether that's going to improve the results that we see. The dosing schedules is going to be big. It kind of plays into the disease biology and also to the immune system biology. But right now, basically, we're seeing a lot of weekly or every other weekly dosing. It would be nice if we could decrease the frequency with which we're being dosed, and whether or not that really plays into how effective these drugs are. And then finally, stuff that I'm really interested in, stuff that we're working on here that another number of our collaborators and groups are working on, is just understanding the biology here, right? So we really want to understand which drug works for which patient, which drug to sequence in what order, right? So which one do we use first? Which one do we use second? When do we use them? What combination can we use? And then also when resistance develops, why? How do we prevent that resistance? So those are a lot of the big questions and things to look forward to. And I think all of us are extremely excited about this, because it seems like this is a new renaissance in multiple myeloma. These drugs are revolutionizing the way that we treat patients. And they seem very, very poised to move into earlier lines of therapy and to really shake things up and improve outcomes for people. Okay, so I thank you very much for your attention, and I'm happy to take any questions.
Thank you, Dr. Diamond. That was awesome. I think the excitement is just palpable, as we talk about things that really even 5 years ago were not really on our, well, I say our, like I'm an investigator, but on the radar. The way that things have just taken off. I do appreciate, I did not know the bispecifics were first developed so long ago and then had a recent reemergence, in the 2010s. So thank you for teaching me that. To my audience, you're welcome to submit your questions in the Q&A. We're excited to hear from you. And I see a couple questions here already, and I expect many more to start coming in. Just thank you again, because it's just so exciting and hopeful. And this is exactly, especially, with this relapse refractory, as you're highlighting these penta-refractory patients who have been able to find success. That's just so encouraging. So I thank you for especially detailing that as well. So Giselle is wondering, you mentioned the loss of taste being one of the side effects of talquetamab. Are there other multiple myeloma drugs, not even necessarily immuno drugs, but others that also have reactions like that?
No, they absolutely are. And I think just on a day-to-day basis, a lot of my patients struggle with this. And it's actually, for people that are on long-term maintenance therapy, just with lenalidomide even, we have trouble with loss of taste. And I feel really bad about it because it's basically when people are on therapy for a long time, the goal is for us to enjoy life. And if we can't taste, it's hard to
That
enjoy life.
takes a lot of life. Yeah.
Yeah. So to answer your question, yes, there are many drugs that can influence that. Lenalidomide can do it to the select person. Sometimes the effect seems to be a little bit worse after having a stem cell transplant. That high dose melphalan can sort of change taste for the long term. I have a few patients that have that experience. And then also, obviously, less important for when you're on maintenance, but when you're getting those high dose steroids, that can also affect taste. And it's a very, very challenging thing to try to address. And I think, it's somewhere where we could really use a lot more work. It's just, it's a very sort of nebulous, hard to understand mechanism. For the GPRC5D directed stuff, that makes a lot more intrinsic sense, right? Because there's expression of this target in the tongue. And so we send the T cells there and you get an effect. That I think we can all wrap our heads around. For the other stuff, it's a little bit, less specific, and we will struggle with that.
Yeah. Yeah. What about specifically in this talquetamab drug and others like it? Do we see, is there anything indicative of how long these last? Are these also permanent changes?
That's a really good question. I honestly, I don't know the answer to that. You'd imagine that taking people off of the drug at a certain point would help their, taste buds regrow. But I couldn't tell you that we just don't have data.
That's okay. Another question here about plasmacytomas. So if you could briefly explain what plasmacytomas are, because there is some confusion about the definition. And then do you consider that a high risk factor? And then I have a couple follow-up questions.
Sure. So in the simplest of explanations, myeloma can cause a couple of different kinds of these lesions, right? So the first is the bone lesion, the lytic bone lesion. And this is kind of what we are used to in bread and butter myeloma. This is where the myeloma is causing an inflammatory response within the bone marrow. And it's kind of inducing those osteoclasts, those bone breakdown cells. It's kind of making them work hard. And so it causes these lytic bone lesions within the bone. And so sometimes those are called plasmacytoma, sometimes. When we talk about plasmacytomas in these trials, it's more in the context of what we call extramedullary plasmacytomas. And this is where we think of it as sort of being a more high-risk marker, because these are the lesions, these are the clusters of plasma cells that are able to grow outside of that bone marrow environment. So they could be in the soft tissue, they could be, basically anywhere in the body that's not the bone marrow, and they're setting up shop there. And as you can imagine, once myeloma has learned to live outside of its regular plasma cell environment, we kind of call it a high-risk feature because it seems to be aggressive enough to have learned how to do that.
Yeah, thank you. You're so good at explaining things. I really appreciate it. My follow-up question to that, it was so exciting to see the extramedullary and other high-risk factored audiences be included in these clinical trials, and especially the results of the tocilizumab and talquetamab combination. They even reported at ASCO the success of their extramedullary. Do you mind expanding on that just a little bit more?
Sure. So, the biology of this isn't super fleshed out yet. There's been a number of, sequencing studies and microenvironment studies trying to understand what makes those extramedullary lesions so much more aggressive. But so far, what we understand is that they are harder for the immune system to target and to penetrate. And it's just sort of a marker of aggressive disease in general. So when you see that there's a large number of patients with this feature on a clinical trial, you know that the drug is working hard, that it's able to kind of address that. And certainly, if they're emphasizing that for the combination, it's kind of just real evidence that this combination of drugs is super effective, and it's able to activate the immune system so much that we can overcome that kind of immune evasion that those plasmacytomas have.
Yeah, I would totally agree. And it's just so hopeful. I know so many extramedullary patients, right, who seemingly, it seems like they run out of options quicker. And just to have such hope presented is just so exciting. As you can tell, I'm all about hope today.
Totally agree. Totally agree.
Deborah has a great question here. In these trials, are you looking at any correlation between the types of treatments patients had previously received and their consequent responses to these bispecifics.
Absolutely. I think that's something that is under big scrutiny. And as you see in all of those GPRC5D trials with the talquetamab, with the faricimab, they're very precise at reporting that patients had gotten the BCMA-directed therapy before, how many had gotten the BCMA-directed therapy before, and then the percentage of those patients that are going on to have a response. It's always hard to tell whether the disease is just, basically, once you've had the BCMA-directed therapy, you basically say that your disease has suffered through more. It's more aggressive because it's seen more, it's lived longer, it's mutated more. So, you always have to take that with a grain of salt. But the takeaway really is that they always do report this kind of thing because we're all very interested. And we want to see, and we do see, that people are able to respond to these agents even after those previous approaches.
Yeah, makes sense. Lou has a great question here. What would exclude you from taking most bispecifics? What does the qualifications look like?
So on trial, obviously, people are very strict, right? They want to make sure that their trial is. I mean, look, if you're a big drug company, what you really want to do is make sure that your trial is a success. So you're going to enroll the patients that are going to be successful. In clinic, that's obviously very different. And what we are doing, I'll tell you the truth, what we're doing over here at Sylvester is the sky's the limit on who can get the approved agents, right? So tocilizumab is right now the only commercially approved drug. And I have not really had a patient yet that I've said is ineligible for it. So we're giving it to everybody that wants a shot.
Which is awesome, if I do say so myself. Speaking of, you mentioned tocilizumab is FDA approved. Where are we at with this talquetamab approval? And I mean, I know you don't know the exact
I
answer, but
don't,
within
but I
rumors of the myeloma specialists, why is it taking so long? And what?
it's always, look, I think that we all want these things to come out as fast as possible, but it is all in the interest of patient safety. So
No, you're
we're
right.
investigating all of the safety signals and the toxicities, and that's why it's taking a while. Suffice it to say that both elranatamab, which is the other BCMA directed therapy, that's Pfizer's drug, that drug, and talquetamab, the GPRC5D, those drugs are poised for approval. So most likely those two are going to be the next in line. And it should be, as far as we can tell from the data being presented and from kind of the word on the street, it should be pretty soon.
Okay, that's encouraging. I want to say I do want it to be safe for all patients. It's do you think the recent removals of certain products from the field have prompted them to take maybe a little bit longer in their approval of these new bispecifics?
That is actually a really good question. I don't know if it specifically impacts the bispecific drugs, but it impacts drug approval on the whole, like across the board. So we've had a lot of drugs, not a lot, but we've had some specific drugs that have been approved based on the early results of clinical trials, the sort of accelerated approval, so much to speak.
Yeah.
And we've seen that in those cases, on the requisite follow-up data, the requisite follow-up studies to prove the efficacy, they've fallen short. And so the FDA certainly is a little tentative about approving some drugs. And again, I don't know if specifically the bispecifics are under that same scrutiny, because
Right.
it's really a different situation, but there is that scrutiny. Suffice to say, I don't think that the accelerated approvals are wrong, right? As long as these drugs are relatively safe, which they've been proven in the phase 1 data, what I really want to see is that we have as many options as possible for people. So I'm not opposed, in other words, to the accelerated approvals.
Right. At the same time, though, you do, if it's going to affect their life and have side effects and everything, you want to make sure it's as efficacious as possible, right? So,
exactly. And that's kind of where they fell short, was that
yeah.
balance, toxicity to efficacy.
Thank you. Carl's wondering, is there any bispecific trials for high-risk smoldering, or is it really just in the active myeloma field right now?
So come on down to Miami. We do have a trial that is going to open very, very soon, looking at using bispecific drugs, either of talquetamab or tocilizumab, in high risk, specifically smoldering multiple myeloma. For exactly the reason I spoke about before, we don't know if it's going to be more effective in that setting, but the theory and what we're working on is that, presumably the immune system is healthier before the disease gets really aggressive. And so if you're going to stand a chance at really, nuking that multiple myeloma before it becomes a problem, that would be the time to use a bispecific antibody.
Super intriguing. Thank you. Jack's wondering, with infections being a major concern, do we have trials in place for fixed duration besides the 1 year? These drug names are so hard to
I
say. So
know.
you know what I'm trying to say.
And the answer is yes. There are many drug companies looking at that. The one that's furthest along in fixed duration, I think is Avastamab.
Yes, thank
There's
you.
also an AbbVie BCMA directed drug, bispecific that's looking at fixed duration therapy. So basically what's going on is that you have every drug company is looking to get into this space. And the way to do that is to kind of dose your drug a little bit differently, give it in a slightly different scenario.
Right.
And that may come off as annoying, but at the same time, it multiplies the number of options that we have.
Mhm.
And so I think it's always a good thing to have that competition.
I completely agree. I would rather have too many options than too little.
Absolutely.
Especially because myeloma is so personal and so unique, and having more options to create that art and science combination is needed. Let's talk a little bit about the GPRC5D. Can you tell I practiced that? CAR T. What do you see the future of that? What kind of phase trials is it in? And then I have a follow-up question about the side effect profile.
Sure. So yeah, it's definitely moving along. There's no stopping that train. I don't know exactly where we are in development for the GPRC5D trial, but it will be further developed. I think one thing that is going to be interesting over time is sort of, as you mentioned, the toxicity profiles, the sequencing. Can I give both at the same time? Can I give one after the other, which is better? And then also the resistance patterns. So some of the work that I think I kind of give you a little bit of a preview. But some of the work I think you're going to be seeing coming out from our group and from some others is just kind of the way that resistance develops to these agents. So we said GPRC5D on the cell surface, it's not essential. So it's much easier for the myeloma cell to lose, right? It can just drop it and there's no harm to the myeloma cell. So in the future, we're probably going to see that the resistance patterns there are quite different than what we see for the BCMA-directed therapies, where that BCMA is really important for the cell to survive. So it's going to be a lot harder for that thing, for that cell to lose the BCMA, but there's going to be potentially a lot of different immune sort of resistance mechanisms or ways that the myeloma cell is going to be able to hide the BCMA from those CAR T cells or from those bispecifics. And that's going to be really important because it'll help us understand which drugs to give when, if we're able to identify any of this stuff beforehand. And certainly if it starts to develop, it might tell us that it's time to switch.
Yeah. This specific question from the audience members said the incidence of neurotoxicity was much higher at the 400 mm dose. Is it lower to the 150 dose? Do you know, as the phases have continued?
Yeah, I'd have to go back and look. I would believe it for sure. We've already seen that the higher doses do give you a little bit more of that inflammatory response. So it could be that dosing less with a higher frequency might be the way to go.
Yeah. You mentioned earlier about the intriguing concept of having like a double hit CAR T where you do both targets. And that was going to be one of my questions for you. I am fangirling over the Tocolysiumab Tocolysiumab combination, how successful it was. Do you personally think the success came from targeting two things on the myeloma cell at the same time? And do you see that replicable in other things like CAR T?
Yes, I mean that is the whole reason that they're doing it. The idea is that you target multiple things, the myeloma cell is less able to resist that, and that's why we're seeing the high response rates. I mentioned earlier that what I really want to see is the high durability of response, because if we're going to make things a little bit more toxic, the bang for our buck is going to be that it lasts longer because the myeloma cell is less resistant. So they are working on that for CAR T. You'll see many abstracts. I don't think there's any front runner for this. It's more experimental at this stage. But there's many abstracts talking about different products that are targeting multiple different targets. There's also CAR T cells that have sort of co-stimulatory domains added. So in other words, trying to augment the T cell response, its durability, its reactivity. Basically, the nice thing about the CAR T cell as compared to the bispecific is that you can really engineer that T cell to do whatever you want. You can add stuff to it, you can take stuff away, you can augment this, you can augment that. They basically have what we call armored CARs right now, just because it's cute. You basically are trying to augment the response by adding extra cell surface markers and different characteristics there. So, while the bispecifics have been really amazing at how quickly you can pull them off the shelf and get something, over the long term, you might see more innovation with the CAR Ts because there's just more customization that you can do.
Yeah, that makes sense. In today's myeloma treatment, okay, what am I trying to say? In the immunotherapy phase of today's myeloma, do you worry about T cell exhaustion, and what do you do for your patients? And I'm going to add one more thing of just at ASCO, there was that interesting poster of the benefits of exercise and its relation to T cell exhaustion. Is that something you share with patients? Anyway, just your whole thoughts on that. That's a big question.
So yeah, there's a lot there. I think, ultimately we're talking about the mechanisms of resistance. Yes, I mean, when the T cells get pooped out and they just aren't really reacting towards tumor anymore, the T cell exhaustion is probably one of the big reasons that people are developing resistance to these drugs. We don't know yet exactly how to mitigate that. I think, when we start looking at the most optimal dosing frequency, maybe if we're giving the drug too frequently, we're pushing the T cells too hard, they exhaust faster. We don't know. We're testing that.
Great point. Yeah.
And then what to do once it develops? Well, that's a good question. There are some groups looking at giving a little bit of chemo to kill the suppressive T cells and to try and reset the system. That's very early on in development. It's sort of a concept that developed with the allo transplants, sort of similarly using chemo to try and kill the T cells that you don't want. So we'll see about that. And yes, it's a big area of research right now. As for the exercise, I'll tell you, I think it's really hard to know if there's a really high association or a high correlation, if exercise directly affects our T cell function. But I will tell you that people who are fit, it's no surprise, like this, you don't have to be a doctor to know this, but people who are fit do better. They're able to roll with the punches better. If there's any toxicity from treatment, they can absorb that better. And they basically just have a higher fitness level mentally and physically to withstand everything. So I think that in addition to fighting this battle against multiple myeloma, you have to stay fit and to try your best to keep yourself in shape for it. And everybody's different. There's no right solution for any one person. But I think the goal is always to push yourself and to make yourself as good as you can be. And for me, I do suggest to all my patients to try and find some level of physical activity that they can use to push their bodies.
I love that, because you're not asking everyone to become a bodybuilder, but you are asking them to stay moving. I love that. Wonderful. Lots of great questions here. I know we have about 5 minutes left, so I'll try to do some rapid fire. So Bonnie's asking, what type of testing is being explored to determine efficacy of target prior to use? Not only the target, but the health of the patient's immune system. I mean, what's being done to make sure that it's going to work?
It's a great question. I think we're all looking to answer it. There is no one test that we use right now to see if this is going to work. There are some studies. I mean, you can kind of get an insight into what people think is what's important. There are some of these bispecific studies that are looking in advance to see what the lymphocyte repertoire is beforehand. They're looking to see, how healthy the immune system is, how many CD4 cells there are, how many CD8 cells there are, and using that even sometimes as exclusion criteria for getting some of these drugs. So you can see already that there are drug companies that suspect and scientists that suspect that basically the T cell, the immune cell function prior to receipt of these treatments is going to determine whether you respond. But at this point in time, when you're faced with the choice of this or nothing, most people don't really care about what the lymphocyte count is, right? It's just a number. We don't really know if that really dictates a response. We're still going to try. And so again, I kind of went off on a tangent there, but there are certain things that we think are probably related. There are certainly things that we're exploring. There's microenvironment testing happening. There's genomic testing happening as correlative studies for all of these drugs. It's basically a mad dash to try and figure this out.
Yeah, thank you. Lori asks a great question here. Her husband's received multiple immunotherapies. CAR T now is on Tocolysiumap. I don't know how to say the brand name of that one. And what besides IVIG, and if you could briefly explain IVIG to people who might not know what that is being done for the immunosuppression? Because as you mentioned, there's multiple infections occurring in people that are responding well myeloma-wise, but then are catching every common cold, every stomach bug, and it's really exhausting.
Yeah, I completely agree. That's one of the big shortcomings with the BCMA directed therapies. We haven't really fully figured out how to mitigate all of this stuff. You'll see that at least for tocilizumab, when people are giving it as standard of care, the number of measures that we take to counteract infections is huge. So people will get an antiviral like you're used to, but they're also going to get, for the first month, usually an antibacterial like Levaquin. They're going to get IVIG sometimes, depending on the person. It can be more frequently than others. And so IVIG, just think of it almost like a blood product, as opposed to getting a donor bag of red blood cells. Instead, what you're getting is a donor bag of pooled antibodies from a number of people with healthy immune systems, right? So the idea is that you get that IV, that intravenous immune globulin, IVIG, as kind of a way to bulk up your immune system and to make it more readily available to deal with some of the infections that might happen. It's really tough to tell how efficacious it is, but we're basically pulling out all the stops here because the infection risk is so high. So people will get IVIG if basically a certain metric, if their own IgG counts are a little bit too low, is usually when people recommend to get that.
Thank you. Going on with the whole infection part of these immunotherapies, what meds are given, and you kind of mentioned some of these, but specifically what meds are given prophylactically?
Yeah.
And then in addition to that, you mentioned Toci. Do you see other drugs being, or, what prophylactic drugs being developed in this space so that eventually the side effect profile is pretty low or extremely manageable? I know it's already manageable, but.
So for the infection prophylaxis, yeah, so we mentioned an antiviral. So these are your things like acyclovir, valacyclovir. The pneumocystis prophylaxis is also a big one. This is a kind of pneumonia that can happen to people with really bad immunosuppression, right? So people often will get put on Bactrim as a prophylactic drug. We do that. Levaquin, which is an antibacterial drug, we'll often give for the first month or so, really when the immune system is at its lowest, and then kind of peel that off, and then IVIG. So there's like basically a four-pronged approach that we'll use to try and prevent infections. For the inflammatory response, for the CRS, right now, Toci is the only one I'm really aware of, but there are other candidates that could easily be used. There's another anti-inflammatory drug called anakinra. Theoretically, I mean, that's been used for CRS and CAR T cells, so you can imagine it would be able to be tried in bispecifics. And basically the use of that could actually enable people to, as we're starting to see, the use of any of these agents, anakinra maybe, certainly with Toci, could certainly help to get people out of the hospital for those first few doses.
Yeah, thank you. So last question here. GPRC5D, the talquetamab, I'm just going to use talquetamab, right? But it showed lower infection rates than BCMA targeted therapies. Is this because it's not really on plasma cells the same way that it's on that BCMA is? Does that make sense? Does my question make sense?
No, it does. It does. This is a really good question. Obviously, we all really want to figure this out. Why is the infection rate lower with GPRC5D? There's actually some really cool work coming out of Tom Cupido's group. They're showing, and they actually just recently presented this. When we've done our microenvironment studies in the past, trying to understand the immune system, more often than not, the granulocytes and the neutrophils are excluded from those studies, mostly because when you look at, like, this is kind of getting a little bit sciencey, but bear with me. When you look at the entire microenvironment compartment, all these immune cells, the vast majority of them are these granulocytes, the neutrophils, and kind of these cells that act quickly for your immune response. And less of them are the lymphocytes and the NK cells and the dendritic cells and all the other cell types. But what you see in the immune studies is that most of the studies focus only on that smaller fraction of cells. And to be honest, a big reason for that is cost. When you sequence single cells one by one, the more you add, the more expensive it gets and the less patients that you're able to do. And so the vast quantities of those granulocytes usually make it so people study immune cells in absence of the granulocytes, and also because it was perceived that they were a little bit less important for that long-term response. So the work coming out of their group is showing that BCMA actually may be expressed on those granulocytes. And so what we see, and what we're certainly seeing here giving tocilizumab, is that the neutropenia that you get when you get teclistamab is very, very, very deep and profound as compared to some of the other targets. You see the neutrophils basically disappear with just a single dose sometimes of teclistamab. And so we think that the infection rate is going to be higher with teclistamab because not only are we causing this kind of total immune redirection away from any possible infectious source and directing it towards tumor, but we're also killing the neutrophils in the process, right? So it seems that, I mean, again, this hasn't been fully fleshed out and fully proven yet, but that's the current theory as to why teclistamab is causing more infections than talquetamab, for example.
Excellent explanation. Thank you. Well, thank you again for sharing your expertise and your time with us. Are there any concluding statements you'd like to make before leaving us today?
Well, I won't take any more of your time. I mostly just wanted to tell you the same thing that I said before, is that right now everybody is learning a lot. There are many avenues for research. Everybody's got a different angle. Everyone's very excited about this, as you can imagine, right? Because it's a renaissance. And this is the immunotherapy renaissance for multiple myeloma, and people are going to milk it for all it's worth and to try and make it as good as it can be for our patients.
Definitely. So exciting. Thank you. I hope you have a great rest of your day.
Thanks. And thanks, guys, for having me. Happy to answer any questions via email if Audrey, you want to give it out to anybody.
Okay, I will. Thank you.
All right. Thanks. Bye, guys.
So to my audience, I'll just keep you for a little bit longer to let you know we have other upcoming events. On the 21st is immunotherapy chapter. We're going to be talking about single cell sequencing. This is something that is just so mind-blowing and intriguing to me. And so if you want to learn with me, because I certainly need to learn a lot about this complex and exciting subject, we can join together on Wednesday, the 21st. Then that night, we also have another Mountain West Regional chapter meeting where we're going to be talking about nutrition and GI side effects. And then the 22nd at 2 p.m. Eastern is our Black Myeloma Health chapter. We're going to be talking about, we're going to be doing exercises with Vanya. She's coming back to that chapter. So the link to sign up for any of those events and more events I didn't mention is found at the bottom of the slide and will be included in our follow-up email. Another thank you to our sponsors, Amgen, AbbVie, Adaptive Biotechnologies, Janssen Oncology, Genentech, and Bristol Myers Squibb. And thank you to each of you for taking the time out of your day to be here. I know some of you took lunch hours from work and some of you are outside the United States and watching this in your evening. So thank you all for being here. I appreciate it. Hope you have a great rest of your day. Bye-bye, everyone.